this evening. So thank you for your questions so far. Keep them coming, and we'll look forward to answering as many as possible at the end of the session. I'd now like to welcome Alison Pittard, Dean of the Faculty of Intensive Care Medicine, to talk about proning for the conscious patient.
In critical care, we've been using prone ventilation to improve oxygenation for many years, and we've found it extremely useful for COVID patients. So it's a natural progression to consider using it in conscious patients to prevent them deteriorating and to avoid the need for invasive ventilation and all the complications associated with that. Most of the available evidence is in intubated patients, so I'm going to discuss that first and some of the other methods that we can use to improve oxygenation so that we can put conscious proning into context before moving on to discuss the physiology that underpins the effectiveness of the prone position, before sharing some of the practicalities to consider before undertaking prone ventilation. So if we look at intubated patients first of all, we know that the mortality of patients who have ARDS is anywhere between 25 and 40%, depending on what papers you read. It's much higher in COVID patients. This is data that has been published by ICNARC, which is our National Audit and Research Centre. So the mortality is significantly higher, particularly in those requiring advanced respiratory support. Now, what we don't know is if implementing basic respiratory support early prevents deterioration, or if this cohort of patients are naturally just less sick. But if we go on to look at non-COVID pneumonia, the difference persists, although the overall mortality is lower than in COVID patients. But whatever we do in critical care and in this situation is we're trying to limit peak and plateau pressures, therefore trying to reduce the incidence of ventilator-induced lung injury. Non-invasive ventilation opens up collapsed alveoli, which in turn improves compliance and reduces the work of breathing. But what it also does is reduces intrapulmonary shunt and therefore improves ventilation perfusion matching. High-flow nasal oxygen has become more popular in recent years, but this only generates a small positive pressure spike at end expiration. What it does do, though, is flushes out nasal air spaces and reduces dead space. Some of the literature that is available reports the benefit of combining awake proning with one of these modalities. But ultimately, what we're aiming to do is to improve oxygenation, avoid intubation and the complications associated with that, and with proning unconscious patients. So what evidence is there for proning in awake patients? So this observational cohort study from China used prone positioning combined with either high-flow nasal oxygen or non-invasive ventilation in 20 patients with moderate to severe ARDS. Now, the underlying cause was pneumonia related to influenza or other viruses, but not COVID, because this study was undertaken during 2018 and 19. However, 11 out of 20 patients avoided intubation. This single-centre pilot study from America looked at COVID patients presenting to the emergency medicine department. They enrolled 50 patients whose median saturation at triage was 80%, and after 5 minutes of proning, their median saturation had improved to 94%. In total, 18 of the 50 required intubation, and the majority of those were in the first 24 hours. So the benefits of prone ventilation are that it opens up collapsed alveoli, it improves lung compliance, and this results in better matching of ventilation and perfusion and improvement in oxygenation. It also helps with clearance of secretions. So in the supine position, there's atelectasis of the dorsal alveoli, and this is due to an increased transpulmonary pressure gradient. The dorsal alveoli preferentially perfused due to the gravitational gradient, but they're poorly ventilated. If we look at this 2-unit model, blood flow is the same to both units, but there's no ventilation to the unit on the right. And this is the situation that we would see in the posterior alveoli manifesting as hypoxemia. As well as atelectasis, we see overinflation of the ventral alveoli. There's also compression of alveoli secondary to direct pressure from the heart and the diaphragm being pushed cranially by the intra-abdominal contents. In this 2-unit model, there's ventilation to both units, but blood flow to only the unit on the left. And this is a picture that we've been seeing in COVID patients due to their hypercoagulable state. So what we're aiming to do is to improve the matching of ventilation and perfusion and ultimately optimise oxygenation. So in the prone position, perfusion becomes less gravity dependent and tends to persist dorsally. We see a reversal of atelectasis, but because the anterior portion of the lung is a smaller volume compared to the overall volume of lung, then this has less of an impact. The posterior lung segments are recruited, and this, along with improved diaphragmatic excursion due to abdominal contents falling away, improves compliance. The degree of shunt is reduced because perfusion pattern remains relatively constant, but lung aeration becomes more homogeneous. So overall, there's improved oxygenation, reduced work of breathing, or in the ventilated patient, reduced pressures and therefore less risk of ventilator-induced lung injury. And in the awake patient, there's increased patient comfort. So we need to consider if the patient's hypoxemia can be improved by proning. This will depend on the underlying pathology. Patients who have a diffuse pattern of disease are likely to respond better than those with predominantly anterior abnormalities, marked consolidation or fibrosis, and obviously it's more relevant where the pathology is reversible. Multi-organ failure isn't an absolute contraindication, but it's difficult to provide some organ support in the prone position. And patients who have raised intra-abdominal pressure are less likely to benefit due to a limited improvement of diaphragmatic excursion in the prone position. So patients should be hemodynamically stable before proning. Their conscious level ideally would be normal so that they're able to communicate any distress. They should be able to adjust their own position, as this will reduce the burden on ward staff. But the most important consideration is patient comfort, and there's no point persisting if they are uncomfortable or if it doesn't actually improve oxygenation. Sometimes putting pillows under the chest and pelvis can help because this frees up the abdomen and allows a greater diaphragmatic excursion, and this is particularly important in larger patients. Need to make sure that they can reach the call button or attract attention in some way. And it is recommended that the prone position is rotated between lateral and upright positions. How you actually do it is going to depend on the individual patient, their tolerance, and the extent of any improvement. This is just one example of how it could be undertaken initially. So you'd start off by turning the patient prone for 30 minutes, see how they improve, and if they have improved, then it's recommended they remain in the prone position for up to 2 hours. You can then cycle between lying on the right side, then sitting up at about 45 degrees, before then moving on to the left side and then repeating the whole cycle. The cycle can be continued for as long as required, but it is recommended that there should be at least 2 hours of prone positioning twice a day. As you're continuing to cycle, it's important to obviously continue to undertake routine observations and news scoring to identify any deterioration. But in summary, it does seem to be a benefit in COVID patients, and it's certainly worth trying in the awake patient. Thank you.